Good evening, everyone. Thank you for being with us tonight. This is a very important issue we're going to talk about. I'm Richard Harding, First Vice President of the Cambridge NAACP, along with our executive branch members, President Ken Reeves and Executive Secretary Aisha Wilson. This is a collaboration with the NAACP, but also with our good partner, AdMeTech, who you're going to hear from for most of the night. And we just want to thank you for tuning in to this very important issue of prostate cancer and men's health. We at the NAACP joined AdMeTech as a advocate for making sure that many of the folks who are affected, mostly men, and in this case, particularly men of color, that we help to bring them information about health that's relevant, timely, and that makes sense for them as they do their best in their health and wellness quest. Tonight's webinar would be led by Dr. Stern, who I'm going to introduce now. And then also, we want to make sure that you take the time to spread this to your friends, even after this particular program is aired. We noticed that last time we did this particular collaboration, that many people who couldn't make it the night of, that they were able to later jump on and join us in this most important conversation. So I'm going to turn this over without further ado to Dr. Stern to begin our webinar. Thank you all who've joined us. Dr. Stern, the floor is yours.
Absolutely, Richard. Thank you so much. And thank you for your partnership. It is our second event with Cambridge NAACP, and very, very proud to partner with Cambridge NAACP, particularly because Middlesex County has the third highest mortality in Black men in Massachusetts. And unfortunately, statistics in Middlesex County are not moving in the right direction. At this point, I'm sure I will introduce a person who doesn't need any introductions. It's President of Cambridge NAACP, Mr. Ken Reeves.
So thank you, Dr. Stern, and the Cambridge branch NAACP is very much pleased to partner with AdMeTech Foundation in this prostate cancer equity project. I must begin by saying we are also joined with another member of our executive committee, who is Mr. Stephen Brown, who is our second vice president. That being said, my role today is really to talk a little bit about the importance of the prostate cancer equity program and what it means to us as the NAACP and to the men of color that we are attempting to reach with the message. You know, prostate cancer is a very real issue for African American men, and we are more likely to have it than other men, and therefore we ought to pay as much attention to it as we can, not to scare anybody. But I'll tell you, in my own case, I went to visit the doctor really about a bump. And the doctor said, well, while I have you, why don't I give you a test to see how you're doing on the prostate end? And I took the test, and before I knew it, I was told that, you know, my numbers were high and there's some more tests I should take, and I was diagnosed with prostate cancer. And unfortunately, I wasn't able to have the kind of watch and wait approach, meaning that the number was high enough that I had to make some decisions about that. Now, mercifully, I have very good insurance and some very good providers. But given all of that, I was like a babe lost in the woods, because I had the prostate cancer treated initially. It was successful for the first year. The second year, the numbers started going up again. Took many tests. It couldn't be determined why are these numbers going up? And they're going up, 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 up. We're in the 30 range. And finally, I went and had a second opinion about what might be going on. And that doctor said, the test you need is not the one that they're prescribing. You need another test, and I will get that test for you. And the second opinion doctor looked all over Greater Boston and came back and said, well, I cannot find it. And so I told this to our former regional representative for the NAACP, the New England Area Conference, and he says, well, sounds like you're sort of lost. So I got to introduce you to Dr. Stern. So that's how we got connected. And I talked with Dr. Stern, and I call her now my fairy godmother because she was able to find this test in New York. And she was also able to arrange an appointment for me to have the test, which you could not get this test, but I was able with her help to get the test. And the test was exactly the imaging I needed, and it answered the question. So this made me a believer that two things are important. This is not something you want to do alone. And in our particular healthcare system, you need someone who understands all of the intricacies of the system to assist you. And that is what this prostate cancer equity program is. We're looking to assist all men of color who may have any question about themselves and prostate cancer to come to us, and we will happily serve them and get them interviewed and get whatever medical evaluation they might need, and let them know what the best path for them is. And further, now I should say in my case, I now, because of that test, I had to go to Sloan Kettering in New York. I'm now taking a medication which has knocked any evidence of cancer out. So a lot of time you hear people talk about being cancer survivors. I don't know what that means, but I do know once you have cancer, even when it is not detectable, it did not go away. So you have to become constant surveillance of this issue. And I'm good with that because I have a good team and I have some great people over at the Dana-Farber that Dr. Stern put me in touch with, who really are so smart and so caring and so effective in making sure that my health care is the top quality health care. And in this country, you used to get better health care the richer you are. And the beauty of this program is you don't have to be rich. You just have to know us. And we just have to get you connected to Dr. Stern, and whatever you need, she's going to help us to get it to you. So that is why we are convening this AdMeTech and NAACP partnership, because we want to help the men of Middlesex County who are impacted by prostate cancer to get the help they need. And I was just having I'll close, have a conversation with Mr. Hart, and he is also for the city of Cambridge in the public health department, and our Men of Color Health Program coordinator for some years. He and I find ourselves in the most interesting role that we love, is that we are able to find men in our city who are really, like I was, lost in the forest, and say, we're here for you, and we can connect you to this AdMeTech sponsored program and introduce you to Dr. Stern and her team, and we'll be able to be sure that you're in the best hands that we could deliver you to. And the last thing I'll say about Dr. Stern, someone had come and their insurance wasn't so great or didn't cover everything. And she says, well, we're able to address that kind of problem. And if a test isn't available here, and it's available in Washington, we'll fly them down to Washington. So that's my idea of help. So my whole political career has been to bring help to people. And that's why I'm excited about this program. And we support it at the legislative level and just in the streets. This is what we need to help men of color in Cambridge, and I'm so glad everybody has turned in. Thank you.
Thank you so much, Mr. Reeves. And of course, Mr. Reeves' story and what we were able to do for him is very much symbolizes what we want to accomplish with Prostate Cancer Equity Program. He came to us upset, uncertain about his care. He did not feel that his providers were driving his care. He felt that he was driving his care. So he was looking for a team who would be in a driving seat. And we put him together with the team at Brigham and Dana-Farber, who definitely has been in a driving seat. But in addition, he also needed very advanced and at that time unavailable in Massachusetts molecular imaging. And we made sure that he got this molecular imaging in New York City at Memorial Sloan Kettering. We chose Memorial Sloan Kettering because it was a little bit closer than National Cancer Institute, our partner, who can provide free care at the, not just, it is one of these exceptions. They usually say you get what you pay for. It is definitely one of the notable exceptions because National Cancer Institute provides free care to every person, every man who is American citizen. And this, it includes screening, it includes every diagnostic test available on the face of the earth. It includes treatment, it includes hospitalization. It even includes free ticket to Washington, D.C. and even back. So we built resources. Our program cannot solve cannot right every social wrong that has not been resolved by, cannot been effectively addressed by state or federal government, of course. But our goal is to make sure that we do our best and leverage resources we build, at least for American citizens at the moment, that so that men will not feel left behind or like struggling alone. So my presentation actually will be dedicated to overview of our program. And then Dr. Ike Madeke from Harvard will review recent advances in prostate cancer care that we would like to bring to every man in Massachusetts, particularly Black and Hispanic men. Tricia, do you mind playing my video? My name is Faina Stern. I'm a physician and president of the AdMeTech Foundation. My thanks to Cambridge NAACP for the partnership in this event. President Reeves just described his experience with Prostate Cancer Equity Program. This is AdMeTech's initiative and the main topic of my presentation. Dr. Ike Madeke will describe recent advances in prostate cancer screening, diagnosis, and treatment. The goal of my talk is to invite everyone to join President Reeves in taking part in the Prostate Cancer Equity Program, which was launched recently to bring these cutting-edge advances in patient care to every man in Massachusetts and eliminate health disparities. Prostate Cancer Equity Program is an integral part of the AdMeTech's ongoing broader statewide program in prostate cancer that created a Massachusetts model of national and global leadership in public awareness, medical education, and research. Our primary focus is on high-risk men, Black Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. I'd like to express my gratitude to the members of the Cambridge delegation to the State House who made this program possible, particularly Senator Patricia Gellin and Sal DiDomenico, Representatives Marjorie Decker and Jay Livingstone. For public awareness and education, our messaging centered on the importance of screening and early detection, critical for saving lives. Early detection is particularly important for Black, including Hispanic men, who are about 2.5 times more likely to die compared to white men. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast with late diagnosis, when cancer is spread to other organs, only 28% of men remain alive at the same time. The centerpiece of AdMeTech's medical education is annual global summit on precision diagnosis and treatment of prostate cancer. The latest 6th annual conference took place in September last year. Our summit has been recognized as a seminal event in shaping the state of the art and future vision for prostate cancer care. Our summit brings together the key international experts representing every clinical expertise involved in patient care to review the best emerging clinical practices. Summit 2022 showed rapid advances in patient care. In screening, our summit supports clinical practice guidelines recommended by the National Comprehensive Cancer Network, consisting of over 28 cancer hospitals and their leading experts. High-risk men, including individuals with Black heritage and with family history of prostate cancer, are recommended to start screening with PSA blood test at the age of 40. Average risk men should start screening at the age of 45. This first, or what we call baseline screening test in younger men, has emerged as one of the most important indicators for identifying men at risk of lethal prostate cancer long-term over more than 10 years. In diagnostics, we have seen emergence of very accurate non-invasive tools such as blood, urine, and saliva analysis for molecular and genetic markers, and advanced imaging, including ultrasound, MRI, and molecular imaging. This non-invasive diagnostics highlighted the importance of PSA screening and shifted past concerns about screening into a dustbin of history. For example, these diagnostics can determine which individual man has an increased risk of life-threatening, rapidly progressing prostate cancer, improve early detection, critical for saving lives, reduce unnecessary procedures such as biopsies and treatment, and optimize selection of personalized care for each man, including careful observation, what we call active surveillance, minimally invasive interventions, or immediate radical treatment. High-risk individuals, including Black men, carry higher risk of both mortality and unnecessary procedures. Consequently, it is critical for them to have access to precision diagnostics that determine for each individual if he should or should not have invasive biopsy or treatment, and what options in clinical care are best for him. Unfortunately, in Massachusetts, compared to white men, Black men are less likely to have precision diagnostics such as advanced imaging, MRI or molecular imaging, molecular or genetic testing, and to undergo life-saving treatment. Prior to undergoing invasive biopsy or treatment, it is important for each man to discuss with his doctor if any non-invasive testing is available to determine if these procedures are actually needed, and if yes, what kind of options would work best for him. Our summit concluded that equal access to high quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches ensuring high quality, personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions, with the mission to save lives and deliver high-quality care. Supporting organizations include Latino Health Insurance Program and NAACP New England Area Conference, with their multiple branches located across the state. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today, and support men every step of their medical journey. This program helps men to find an expert for the initial or a second opinion in person or virtual visits. Any Massachusetts man age 40 and older can take part. Our priority focus is on Black, Hispanic, and Latino men who are at high risk of prostate cancer, delayed diagnosis, poor quality care, and death. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities. Experts of the prostate cancer equity program can address any questions about prostate health, from assessing an individual healthy man's personal risk of prostate cancer to informing men about all available options before and after screening, biopsies, and treatment. We are committed to supporting men during every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how doctors involved in this program take care of our families and friends. This process consists of three components. First, AdMeTech Foundation Administrative Coordinator collects basic information and matches individual patients' needs and the appropriate state's experts for clinical care. Second, a clinical organization designates a patient navigator who works with multiple schedulers to expedite a medical visit and related needs, including registration into healthcare system, transportation, and financial assistance if needed. Third, if an expert recommends any next steps, AdMeTech's coordinator, educator, and patient navigator work with patients on the appropriate follow-up, such as, for example, testing or treatment. I'd like to share with you a few recent examples of how prostate cancer equity program has been making a difference. This is a case of a Black man with a history of prostate cancer who is currently being treated. On May 15th, his doctor informed him that his scheduled treatment could not be provided due to problems with his insurance coverage. He got very upset and shared his situation with a leader of the Men of Color Health Awareness, MOCA, our community partner in Springfield. This leader in turn referred him to us. On the late afternoon of May 26, right before the Memorial Weekend, this man contacted us and appealed for help. Our primary goal was to restore his treatment as soon as possible, and we immediately reached out to Dr. Mitchell Sokolov, chair of urology at University of Massachusetts, and his team to secure their support. On May 30th, right after Memorial Day, UMass Urology provided guidance to this man how to address his insurance issues. By Friday, the same week, on June 2nd, the insurance issues has been resolved, and the appointment with Dr. Sokolov was scheduled at the earliest opportunity in early July to resume his treatment. The following Monday, on June 5, a MOCA leader who referred this man to us heard about what happened and asked us to help another man with prostate cancer in a similar situation. He also asked for a second opinion for his own urological issue and received an appointment with a leading urologic expert at Mass General Brigham last week within a few days of his request. This is a story of a 56-year-old man. You could please disconnect the video. Thank you so much. This story is, of course, when the man from Springfield came to us, it was probably one of the most distressing moments of my career as a physician to hear that cancer treatment was stopped without, in this private urologic practice that was taking care of him. They just stopped treatment and without giving any options, without sharing information about any resources, any alternatives that can be used to continue his cancer treatment. It was very distressing to us to hear his story, and we are very grateful to University of Massachusetts as one of main partners, whose navigators immediately contacted financial assistance at UMass who took care of this man. And that's the difference between coming to us and coming to actually a clinical institution, because what we've put in place is an infrastructure, and we can figure out which clinical institution can best help an individual man with an individual set of problems. Another very typical scenario that we are dealing with, a number of Black men are coming to us and telling us that their urologic providers are telling them, your insurance is too limited, you will not be able, we may not be able to provide the best diagnostic tools, we may not be able to provide the best treatment tools, but we will come up with a compromise. So you can imagine a man was just diagnosed with prostate cancer, and somebody is telling him he will not be able to get the best. So this is a pretty typical scenario. And of course, our job in prostate cancer equity program, we made it our job that men, particularly Black and Hispanic men, are connected to the best care available today. Once again, we may not be able to right every social wrong. We may not be able to come up with perfect solution for each man, but we are committed to make sure to utilize our resources in the best possible way for each individual who is looking for help. So you're welcome to contact Cambridge NAACP or our coordinator if you have any questions about our program or if you need help. Trisha, do you want to introduce yourself? Trisha Kinney is our administrative coordinator. Trisha?
Yeah, absolutely. Hi, everyone. Thank you so much for joining us today. So as Dr. Stern mentioned, I'm the coordinator of the Prostate Cancer Equity Program. So essentially, when you contact us, I would be your first point of contact and would be able to give you more information regarding the Prostate Cancer Equity Program. So I work directly with the healthcare system's patient navigator to ensure that each individual's process of finding a provider, seeking support resources, and securing health insurance is seamless. And that is exactly what the PCE program strives to do. So whether you are looking for a second opinion or screening, please do feel free to contact me. I would be happy to answer any questions you have about the program and help you find the resources you need. I'll also be putting all of the contact information in the chat box.
Thank you so much, Trisha. Erin, would you like to say a few words? Are you in a place where you can uncover yourself, because I forgot to uncover myself for a minute.
Hi, everyone. I'm Erin Roberts. I'm actually just got brought onto the team in the marketing and communications department. Here, I also help out with the graphic designs of the flyers to actually promote the virtual events for the NAACP.
Thank you so much, Erin. Erin is a new and exciting addition to our team, and Erin will be trained to join Tricia in becoming one of the first point of contacts for prostate cancer equity program at AdMeTech Foundation. At this point, I would like to, unfortunately, Dr. Ike Madeke, who is a urologist at Harvard Medical School. He is a part of fellowship for urologic oncology at Harvard Medical School wide program. Was not able to join us today, but he sent his video. He is currently unexpectedly on a flight during this event. And Ike is a remarkable individual who is doing outstanding pioneering research at the Dana-Farber Cancer Institute, as well as being a great clinician. And his research uniquely is focused on discovering a gene which is very specific to African-American men. At this point, Tricia, do you mind playing Ike's video?
Good evening, all. Sorry I can't be there live. Unfortunately, I was at a meeting. I had to change my travel plans, so I'll be in the air when the meeting is taking place. Nonetheless, my email is available for any questions that anyone might have if they want to reach out offline. So I'm Ike Madueke, a urologic oncology fellow here in the Harvard Combined Fellowship Program. Today, I've been tasked with discussing the recent advances in prostate cancer treatment. I would like to start by, just saying that prostate cancer screening saves lives, right? And so this is a schematic of the 30-year incidence of mortality of men in the U.S. Broken down by race. And what you appreciate here is that the greatest impact with regards to incidence and greatest impact with mortality was seen in Black men. And so there's a 50% all-cause mortality for all comers, but again, that's greatest in African-American men. If you look on the left-hand graph, you see a small uptick in incidence, and that really was after the 2011 recommendation by the U.S. Preventive Task Force to stop checking PSAs. What we have seen clinically within 5 years of that recommendation is a decrease in men presenting with localized disease, an increase in regional disease, and an increase in distant metastases. And so the other studies that have stratified this by race, and that impact seems to disproportionately affect African-American men. And so the USPS task force has backtracked. It now says PSA can be based on an individual decision. We know it's not a perfect test. It can be elevated for other reasons, a big prostate infection, inflammation, procedures. So it needs to be taken in the context of the whole clinical picture. But what is not debatable is that screening saves lives. When I think about prostate cancer, I'd like to talk to a man and center a discussion around 3 questions. The first is cure possible? Is cure necessary? And the final question, is cure possible when it is necessary? And these are important questions because we know that all prostate cancers are not equal. All prostate cancers will not necessarily kill you. In fact, the vast majority of prostate cancers are diseases that we will die with, not from. But we need to be able to find the bad actors and treat them accordingly. With regards to detection, all our men here in the MGB system will get an MRI before the initial biopsy. A lot of work has been done in the MRI space. We know that it decreases the detection of what we call clinically insignificant disease and increases the detection of clinically significant disease. And so most of our men here will get an MRI before initial biopsy. In regards to how we obtain the biopsies, here we essentially have switched completely to what's called the transperineal approach. And so traditionally, for any men who've had a biopsy over the last few years, typically a probe goes into the rectum, and then you put the biopsy gun through that probe, through the rectum to get your samples. Here's a schematic of how we do it in the office. Probe goes into the rectum, and we go directly through the skin into the prostate. Essentially, our sepsis rates or serious infections after biopsies have essentially gone down to 0%. And that's about 1 to 2% if you go transrectal. We don't use any antibiotics. And so for places where we continue to see increase in resistance, we essentially have addressed that by not using any antibiotics. We get a better sample of the peripheral zone. This is where about 85% of the prostate cancers will originate. And then we also get a better sample of the anterior prostate where some of these cancers can hide and they're difficult to get from a transrectal approach. And then finally, for men who've had a previous negative transrectal ultrasound biopsy, we get a different sort of angle through the transperineal approach. Once a cancer diagnosis is made, usually if it's localized, the first decision tree is active surveillance versus active treatment. All right, so what is surveillance? Surveillance essentially means you're watching, right? So there are different surveillance protocols, but essentially entails serial PSAs, serial digital record exams, serial MRIs. Again, the interval can change, and then serial biopsies. Again, interval changing based on what is found. Really, the recommendation for surveillance versus treatment is based on the risk category the patient falls in. And so this is the AUA NCCN risk classification guideline. It's based on your clinical stage, your PSA, and your grade group. And so this is your low risk here, PSA under 10, grade group 1, what's called the Gleason score of 6, and a clinical stage of T1, T2. Intermediate risk, there's 2 flavors, favorable and unfavorable. Some people will offer active surveillance for the favorable group. And the high risk, this is where you do recommend treatment, whether that's surgical or radiotherapy. And then you have the very low risk group, which definitely should not be treated. With regards to active surveillance, some people postulate that it's risky to surveil younger men, as you might miss that window of cure. This is data from our group that's shown that it's very safe in young men, and they don't miss that window of cure. Should disease progress, men are able to achieve cure. And then Harbor wants to move over to active treatment. So again, that's that risk category of unfavorable, intermediate, and higher. There's several options, surgical options, and various radiological options. We'll talk about some of the advancements in the surgical space. So again, that's just reiterated here. Traditionally, there used to be an open radical prostatectomy. Essentially, most places in the country no longer do that. It's now done with the aid of a laparoscopic robotic device, the most common one being the Da Vinci platform. And again, brachytherapy of the seeds. Most people don't do that anymore. And then there's different forms of external beam radiation with different delivery methods. And we have all of those here. This is that robotic platform I was talking about. You have your surgeon in the console on the side, the patient is over here, and then the robotic platform is docked above, and then the procedure is performed. And so with regards to the robotic platform, the one that's most common and most used is the multi-port platform. So again, you have 4 robotic arms, 1, 2, 3, 4. You have an assistant arm here, the robot is docked, and you perform the procedure. The prostate is located down in this region, and it's removed. The connection is sewn back together, all on the inside, and then the prostate is typically removed from this middle port. So the big advancement in this space is what's called the single port platform. Again, it still uses 4 arms, but it's just 1 port that goes through the midline. This is how it looks schematically. Again, there's still 4 arms, but these are able to go into the inside, expand on the inside, and have the same work done. A lot of data has been shown that the outcomes are essentially the same. Is another schematic here of the single port robot. So again, 1 incision, 1 port. Men are able to have this procedure done while they are laying down, as opposed to an incline. And so for some patients who have problems with, say, difficulty with breathing, or they're more heavier set and can't really tolerate an incline, this is a great advancement with regards to keeping them flat. from a pain standpoint, it's not really a painful procedure. Nonetheless, this makes it even less painful. Most of our patients we've shown from work in Chicago to use less narcotics when they undergo the robotic single port platform. Also, we send them on home on the same day and without any recourse. But ultimately, I just want to kind of stress that again, when you meet a surgeon and you're discussing these decisions, the surgeon is sort of a tailor, right? So you're choosing a tailor. You're not choosing a sewing machine. So, if your surgeon does not have access to a single port, that doesn't mean that you shouldn't have the procedure. I'm just highlighting some of the advancements we have from a surgical standpoint. So let's move down to radiation. So again, we have a very involved radiation oncologist team here at the MGB. Again, with protons, photons, and other modulated therapies. Nonetheless, one of the advancements in this space is the use of space OR. This essentially is a hydrogel that's injected between the prostate and the rectum and has been shown to decrease the side effects that radiation can have. Specifically, there are fewer bowel complications, fewer urinary complications, and fewer sexual complications. And so most of the men, or essentially almost all our men who undergo radiotherapy here will have this space OR placed. When disease now becomes advanced, no longer localized, the androgen deprivation or the removal of circulating testosterone still remains the mainstay of treatment. However, there have been a few advances in this space. Relugolix was the first oral FDA approved gene hours antagonist. This was in December of 2020. Immune therapy, you have CIPT. This was the first one that was approved in the metastatic castrate-resistant space. It's not usually widely used. And then you have pembrolizumab, which was approved in June of 2020 for patients expressing these ligands. Unfortunately, in this space, for the trials were just recently stopped as they did not show a improvement in overall survival or progression of disease. Interestingly, there was some unpublished data showing that there might be more expression of immune reagents, if you will, in men of African descent. So they might be a population that might actually benefit from use of this drug. Finally, rucaparib and olaparib, these are PARP inhibitors. They were approved in May for metastatic castrate-resistant prostate cancer with DNA mismatch repair mutations. Again, similarly, there's been some conflicting data in this space with regards to the outcomes. Again, this is another space where African descent men have differentially expressed genes that might make them actually more sensitive to these medications. I just want to end by highlighting some work out of the VA system. Here we looked at a lot of men that had equal access to care, and with the question of whether addressing access to care might improve or remove the disparities we see with regards to outcomes in African American men. And just real briefly, men who presented with prostate cancer tended to skew younger in African American men compared to your Caucasians. Your PSAs were actually higher at 6.7 compared to 6.2. However, even though the median PSAs were higher, they actually were less likely to have higher risk disease with regards to Gleason score at 18% versus 19.7%. But really the punch here of this study was that there was no difference in all-cause mortality or prostate cancer specific mortality between African American men and Caucasian. And in fact, when you looked at overall survival, when they had equal access to care, the African American men actually had a slightly better advantage with regards to overall survival. And so the argument here with this group is that when you level the playing field with regards to access to care, actually you address a lot of the disparities that we see in African American men. And so, by conclusion, again, PSA-based screening is and detection remains the standard. PSA ultimately definitely saves lives. We just need to do a better job of not overtreating men who have indolent disease, and getting men who have aggressive disease treated in a timely fashion. I don't really talk much about secondary biomarkers, but multiparametric MRI is a great one, and we use that on almost all men here under initial biopsy. Advances that we made in the surgical treatment of localized prostate cancer. We discussed some of the new advancements in advanced cancer, and there's ongoing research for improved risk stratification and treatment. And so ultimately, you know, I just want to leave you with some words from the late Desmond Tutu. You know, there comes a point where we need to stop just pulling people out of the river. We need to go upstream and figure out why these men are falling in. And I believe that this is what we're doing here at MGB, where we're actually now going upstream and finding out why men, in regards to prostate cancer, keep falling into the river. So with that, thank you very much. My email is available. You can reach out to me with any questions offline, and I hope this was informative. Thanks so much. Enjoy the rest of your meeting.
We will be happy to address any questions anyone can have. Do we have any questions on Facebook, Thomas?
While we're doing that, Dr. Stern, I just want to welcome Patrick Samuels, the exalted ruler of the Massasoit Lodge, who joined us. There's no politicians, but he may be the closest thing to a dignitary here. Welcome, Mr. Samuels.
Welcome. Thank you for joining us, Mr. Samuels. Any other questions? Any other announcements?
If there are no questions, I just throw one out. Maybe Dr. Stern, you could answer this, and I appreciate the thorough presentation. So can you help me to understand from the last presentation, was the doctor just showing us the advancements, or was, from your interpretation, was he recommending any particular treatment? I only ask that because I know that the advancements have been, it's a great leap from, say, 10 years ago, even 7 years ago. So I just was wondering if you could speak to, and I know each individual case is an individual case, so I'm not, notwithstanding that, but can you just speak to kind of some of the advancements as it relates to the decision-making process that one might have to contemplate?
Actually, from my perspective, Richard, I believe that Dr. Madeke very clearly stayed away from any recommendations. He shared the data supporting various approaches and for various groups of men with specific clinical situations. But he did not actually, he's a urologist, he's a surgeon. He was, he spent a significant fraction of his talk talking about advances in radiation treatment.
Yes.
So from my perspective, he did not actually side with any kind of new therapeutic approaches. He just presented the best data we have. Now, if I were to give a brief overview, if I were to rephrase actually what he said, I would say that there are three major categories of men with prostate cancer. One category, men with very low risk prostate cancer. By that, we mean that this prostate cancer is extremely unlikely to progress, cause symptoms or trouble. These are men with very low risk prostate cancer. And this is a significant fraction of men, but I would say about 1/3 of men. And if not a little bit more. And for these men, the key issue is to identify this man correctly and not to mistake high risk men with low risk men. For low risk men, we have just what we call active surveillance, careful observation, no treatment at all, no treatment-related costs, no treatment-related complications, okay? But once again, we need very precise diagnostic tools to make sure that men really are in low-risk category. And these men can be watched carefully, perhaps on 6-month basis or annual basis with non-invasive or minimally invasive diagnostics. They also do not need to be treated. They also may be good candidates depending on their specifics of the situation. The worst possible case scenario, if diagnostics are not clear whether or not this man is on low risk or higher category, we can administer minimally invasive treatment that can be done in outpatient clinics with very minimal discomfort to patients, very minimal costs. Now, there is another category, intermediate category. Once again, if the best diagnostic tools show that it is not low risk, it is not high risk, it is intermediate category, the treatment approach would be dependent on the age. The younger the man is, the more testosterone, male hormone, is produced by the body. The male hormone drives progression of prostate cancer. So if men are on a younger side, let's say younger than 60, I don't think any surgeon would be comfortable not to treat younger men and to do minimally invasive treatment, not to do surgery, radical surgery, because every time you leave a tissue behind, prostate tissue behind, in the presence of male hormone, you have a driver of cancer generation and progression. So it's not really the current state of the art for younger men not to have surgery or radiation treatment. Now, for older men who do not have as much testosterone, particularly really old men who have very low level of male hormone, treatment may not be necessary, or maybe they can get away with minimally invasive treatment for intermediate category. Now, and the scope of diagnostics right now is extremely precise. So we know with great precision what to do for each individual man if we administer these diagnostics. And then there is high risk category. And once again, we want to make sure that we did the best diagnostic testing we can to make sure that these men are in high risk category. High risk category men, meaning the cancer appears to be aggressive biologically on histology under a slide, under a pathology slide. These men need treatment. The question is what treatment they will have, what treatment will be best for them. And once again, precision diagnostics determine precision approach to each individual man. Some men will need just radical surgery or radiation. Some men, depending on the age again, would need administration of treatment that counteracts male hormone, and therefore will prevent male hormone from making cancer come back or to grow. And some men, depending on the stage, etc., may need aggressive systemic chemotherapy, in addition to surgery or radiation treatment. So that's basically low risk, no treatment, intermediate risk, or low risk, sometimes minimally invasive treatment, intermediate risk, depending on age. The younger man is the more aggressive treatment it should be. The older man, the less aggressive approach will be. And the high risk man, that's where treatment is life-saving. It is unarguable. It must be done to save lives.
Thank you.
Okay. Does that answer your question, Richard?
Yes.
Yeah.
I
Yes.
have a question and some information. If I should have remembered during my prefatory comment to mention this, that after I was diagnosed with prostate cancer, I called my brother to tell him that I was diagnosed with prostate cancer. He should go check himself out. And of course, he had it as well. So I want our audience to know that this is something that really runs in families. So you really want to know your family history. And this is how, in Black families particularly, not talking about medical issues is not a great idea. And my brother was able to go and get treatment, and his cancer, his prostate cancer did not return. Now, unfortunately, I lost my brother last year to pancreatic cancer, which is a whole other awful enemy. But it's important to know that this can be hereditary. The other thing I would say, Dr. Stern, my guys, those pictures were extraordinary. Extraordinary in their graphicness. So I want to know more about removal. So that's in the third group. And it seems to me that while aggressive treatment may be necessary, if you are diagnosed and told you should have it removed, do you have time to have a second and third opinion to decide if this radical approach is really for you?
It depends. I think when your physician is telling you that you have aggressive prostate cancer and the treatment needs to be done immediately, I would be very uncomfortable to encourage men to seek second opinion. That may take a while. At the same time, I also feel very strongly what I do for myself, what I do for my family, that's what I recommend other people. And if you do surgery, you cannot undo surgery. And you have to go into surgery with absolute trust, not perfect, but confidence, real confidence in your physician and real clarity. It is the right option for you. So if it takes a little time to get a second opinion, to be absolutely clear about it, I would suggest, yes, if your physician is saying your surgery needs to be scheduled, and it needs to be scheduled now, schedule surgery. But while you are waiting for surgery, get a second opinion. The importance of confidence and clarity of your decision, the importance of confidence and comfort for your physician cannot be overstated. You need to choose the right tailor. I agree with Dr. Madeke. The right tailor that works for you. Even the world leading physician may not be the best match for you. So the right tailor and the right match, it's like a relationship, right? Sometimes we had a patient who did not like his physician. He came to us. We got him physician. He had a conflict with him. So we found him finally a physician that works for him. Sometimes I feel like in prostate cancer equity program, we are matchmakers. but in a way, the physician, obviously we chose them for a reason, not only because of their extraordinary clinical skills, but because of the right personality. People who are great communicators, people who have great personalities, people who are compassionate and passionate about addressing disparities, which are so unfair and unjust. By the same token, it's like relationship with your physician is like any relationship. It may not be the perfect match. So we see it as our job to make sure that men are comfortable with their physicians, and they're confident, and they're clear about their choices.
Dr. Stern, we have one in the chat. I could read it if you want.
Sure.
I'm concerned about how the dreadfully long wait list for new primary care physicians in our healthcare system logistically complicates the effort to improve early detection. I don't know if you want to speak to that.
Yeah, Steve, do you want to elaborate on that, or did you communicate your concern completely?
Well, I'm I'm blessed with having, a healthcare with a physician, but I'm just, and most folks I know in my network do, but I'm just aware that there's many places, maybe not 02138 so much, but where the wait list for getting a primary care physician who would then refer someone to a urologist, that has, to me, that seems like that has to also happen. And to just assume that everyone already has a established a working relationship with a primary care physician or an outpatient clinic. That's not, I feel like that's a little bit, that's assuming oftentimes too much.
Yeah. Steve, a couple of things, if I may. First of all, particularly if you already have a private care, primary care physician, you do not even have to, what is important to remember, 1 in 8 men is stricken by prostate cancer.
Right.
If there is, it's such a common disease, okay? If there is any concern about waiting period for you to see your physician, you should have an opportunity to call, to either connect with your physician briefly, or his nurse practitioner, or his physician assistant, or somebody in his office to request PSA blood test while you're waiting for an appointment, so that you will be able to discuss results of PSA test during your appointment with your primary care physician. And then to follow up to make sure it is not above 3. If it is above 3 and you are younger than 70, that's when you need to ask for referral to urologist. If you have any concerns about that, if any friends that you have any concerns about that, come to us or send your friends to us. We'll take care of it. For a very simple reason, because we are working with patient navigators, for example, at Mass General Brigham, which is much more relevant than UMass probably for Middlesex County. And what happens, if necessary, we can ask patient navigator, if men are not comfortable to do it, patient navigator at Mass General Brigham will do it for us, or for these patients. Okay, they will request PSA testing, they will do whatever is necessary. Okay, so there are ways to get around the system. Sometimes I think about prostate cancer equity program as the ways to get around dysfunctionality of the current healthcare system, if you will.
Thank you.
Okay.
Well, could I say one other last thing? Not only is this current system often dysfunctional, in areas like when Dr. Fain helped me to get the test in New York, just filling out the paperwork with the folks in New York was so time consuming. And no sooner than we finished filling it out, they told us, well, now it's 3 weeks old, so you have to start again.
Yeah.
So this is, when we talk about dysfunction, that's so real. But the thing that I'm finding is that this is also a system that does not understand how African American men need to receive information. So I had a lovely experience where I went to see a doctor, I don't need to say where and when, and he says, well, why don't you just check in this weekend, we'll collapse your lung, we'll take a look at what it is, and I'm thinking, you cannot say to an African American man, let me collapse your lung this weekend, and we'll see, and then follow that talking to your intern to say, why doesn't he just decide now? We don't work like that. We need to think about it. Collapsed lung to us is, you might as well say, let me cut your head off. you have to know who this is before you. Discussions about collapsed lungs don't happen with us every day. That we have to like process that. We need, and that's the beauty of, I think, the AdMeTech program, because I felt I need somebody in addition to me who's familiar with things. So luckily I have a great primary care physician, and I also have a great spouse. And it took the three of us on Zoom to discuss pros and cons to decide, well, maybe something less radical will give us the same result. And in my case, it did. So I never had to deal with Mr. Collapse lung, but I needed those other brains. And that's what AdMeTech is offering. More brains to help you. This is a system that's not made for us. It's difficult for us to navigate. It asks things of us that we don't know how to respond to. So thank you for inventing the help that we need, because it's not something lay people can easily do. And as I like to say, I have a Harvard education, I taught at MIT, I had all of that. And I'm a babe in preschool. I need guidance and hand-holding and information. And that's what this foundation is providing us with the Prostate Equity Program.
Yeah.
So I just have to say thank you for it.
Thank you so much, Mr. Reeves. And it's also important for me to say that when people are facing diagnosis, or people are afraid of what diagnostic tests will show, or they're told they have a problem. I mean, we as human beings, we become very vulnerable. And the first thing that goes out the window is common sense. I just shared with, a couple of weeks ago, I shared with Mr. Reeves that as a physician, I did something that was laughable when I had dental emergency, right? Because I got so scared, my common sense, my medical thinking went right out of the window. I just needed this to be taken care of right before I needed to manage a major global event for 3 days in a row. And I just needed to take care of it right now, right? So all the cake that goes into normally, like normal thinking that I would provide to other people went right down the window. And I need somebody to advise me, somebody who is an expert, clinical expert. I need to advise me just as much as men who do not have medical degrees and who are vulnerable because, one, they are afraid that they are at risk of prostate cancer, and then they're told they have prostate cancer. So it's we understand that very well, but what we also clearly understand, there are clear disparities, even in Massachusetts. With universal access to care, there are clear disparities, and they cannot be explained. They cannot be explained by what is happening right now, outside of people falling through the cracks. People are not supported enough. People are not supported in appropriate cultural way. People are not supported sufficiently. And that's what our program is all about. To ensure that each individual who comes to our program is supported every step of the way. Any other questions? So I will leave you with an impression of our program as a matchmaker, and as with the commitment to get around the deficiencies and dysfunctionality of the healthcare system.
Yeah, just Dr. Stern, one quick question. So I'm thankful because I run a program in Cambridge, as Mr. Reeves said, for 22 years. And I think that one of our most important programs that we lost was our Health Navigator program. And so I think we should, well, one thing I would just state, and you could speak on it or not, but one of the interesting things about prostate cancer is that much of the work I do is in prevention and then management. And I haven't really found any strong credible information on what prevents prostate cancer. It's kind of like if you're a man,
It's none.
something will happen. That's
really
one
none.
thing that's odd in my work. The other piece is that part of what I think is one of the critical pieces is two parts to dealing with the man who's navigating through the system. One is the forms and the consents and all that stuff. That's a very, very, very long and arduous process. So one should think about creating a program or system or service that helps people just to get through the paperwork. Because as you know, dealing with insurance companies and primary care and all the other referral systems that are in our healthcare system, no matter how good the healthcare system is, can be daunting for one who doesn't do that, particularly if their technological skill set isn't at a particular place. So I think we should, moving forward, think about that as being part of the navigation, not just making sure they get the appointments and scheduling them, but how do you fill out these forms and making sure that people do
that's
that?
exactly what patient navigators at Mass General Brigham and UMass do.
Perfect.
The challenge we do need to address right now is we do not have structure to support men who need to fill out paperwork for National Cancer Institute. And I would really appreciate your, and it's a lot of paperwork, okay? And I would really appreciate your guidance, perhaps how we can work together, because we are not a HIPAA covered organization.
Yes.
Unless we do not charge for medical services, right? We do not charge for anything we do, okay? So it's really important for us to identify partners who are covered by HIPAA, whose job will be to help men fill out the paperwork.
No.
And then they will get free care.
No, absolutely. And then my last question would be, can you speak to any services or individuals who may be within the network that can just have that kind of talk to patients about their fears, their speculations, their perceptions of what's going to happen? I know that for men, one of the big things is what's the sexual function going to be before and after. And many men that I know are choosing treatment with that as a major factor. And I know that sometimes there may be a conflict in the philosophies around what are the different, whether it's surgery, whether it's radiation and all the things in between. But I was wondering if there was someone who's in a network that could speak to men about that, because I do think that while many men won't necessarily admit it, in the conversations that I've had over at least the past 15 or 20 years, that has been a chief concern of most of the people that I know that have gone through this, both before and after they actually have picked a treatment. And that's why I'm a big advocate, and I think you kind of said it in your remarks, of having a second opinion. I think that if there is the time with anything, you should have a second opinion. It doesn't mean that that second opinion will necessarily change your mind, but I would never understand why you wouldn't do that just as a practical matter in any decision that you have to make that's major in your healthcare continuum.
I agree. Yeah, I agree. So to address the first part of your question, prevention, okay? Unfortunately, we do not have data that anything can prevent prostate cancer, but there is commonsensical sort of approach that whatever good for heart health is good for, in terms of diet and exercise, is going to be good for prevention of cancer. There is not much data in that area, but this is just commonsensical approach. As far as second opinion is concerned, I cannot agree more. I think second opinion, when you hear a second physician, particularly prominent physician, who is telling you you need, it's just another conversation about options. And hopefully it will confirm an opinion of the first physician. If not, a patient needs to ask as many questions as possible. But it is really a job of a physician, and we trust our physicians that we work with in Prostate Cancer Equity Program, to describe fully to every man what kind of treatment options may be good for him, what are the options, and to describe pros and cons of each option, so men can choose with degree of comfort. And somebody,
Thank you. I think there's one more in the chat and we should close. If
yeah.
you want to read it or you want me to read it? You want to read
no,
it?
that's okay.
Okay.
Actually, Mr. Harding, please, I think people would appreciate to hear it without Ukrainian accent.
Okay, I'm going to do my best, Dr. Stern. Okay, hold on.
Thank you.
Let me go. When one thinks about Black health, whether it be Black maternal health or prostate health, why are Black people at such a disadvantage when it comes to health in these ways? So that's kind of one part. And then for the women and spouses who are typically in the background and supporting their male partner, what are the best practices that can be shared on getting the support needed? I hope I didn't chop that up too much, but I think you get the gist.
Isha, as usually your questions are right on. If I can start with the second part of the question.
Absolutely.
Women. Guess who makes most decisions? Over 70% of clinical decisions in American households are made by women. They are not at all in the background. They are right up there in foreground, I would say. Okay, so it's very important for us to see participation of mothers and spouses and sisters, etc., or daughters for that matter, because these are people who will be pushing and pulling. And I'm always thinking about this funny advertisement in one of the prostate cancer charities. Very attractive African-American couple, very beautiful, two human beings, and a woman, young ones, and a woman is sitting in a man's lap, looking at him, pointing finger at him and saying, no testing, no lookies. Okay, so basically the role of women cannot ever be overestimated. So this is to address your second question. The first part of your question is Black health. It's really a perfect question that I was tempted to address in my presentation, but did not want to go into too many details. If you look at VA system or at military health system that has equal access to the same care, what is absolutely fascinating that very large studies for military and veterinary systems show that with equal, particularly mandated as they set up, approach to prostate cancer screening, there is no difference in mortality between Black and white men whatsoever. And we are talking about studies that involve thousands and tens and hundreds of thousands of men. What else is interesting? If this outcome are not different for Black and white men, irrespectively of level of education and income. And these studies bring into a very sharp focus for the rest of the society that equity in care can be achieved even with such dismal situation as prostate cancer. Because if they could achieve equity in equal access system, we will be able to achieve equity if we will assure equal access to high quality care. Or you just put me right up there on my favorite topic. Aisha.
Thank you. So I want to thank AdMeTech for the great presentation, very informative. I want to thank all of the guest speakers, whether it be through video or other testimony on our Zoom webinar today. I want to thank, obviously, my partners at the NAACP and others who have signed on. I want you to remember to tell your friends that there'll be a link available very shortly, if not immediately, that can be shared to other folks who you believe need to hear some of these important messages and understand these resources. And we want to thank you once again for spending the time with us. And we look forward to you staying in touch and being a part of our ongoing efforts to bring advocacy and shed the light on prostate cancer and men's health in the name of equity. So I'm going to sign off now. Thank you, Dr. Stern. Thank you, President Others. And this concludes our program. Thank you again.
So much. Thank you.
Thank you, Mr.
Have a nice
Hart.
evening.